Thank you, Dr. Sandeep. I must thank Dr. Dinesh for including me in this instruction course. And before I start, I would like to add not only the emergency drugs we need to be handy while doing fluorescent angiography. As per the requirement, I think we should be even prepared for the CPR. We should be accustomed with the CPR. In case of emergency, we should be ready for all those things which is required to manage the patient. So the topic given to me is a pattern of fundus fluorescent angiography. I have no financial disclosures. To start with, we must understand the anatomy of the retina. That's 1/3 is supplied by the choriocapillaries. There's no vasculature of the outer 1/3, and the inner 2/3 is supplied by the retinal vessels. This is how the placement of the vasculature in the retina, and we would understand what's the fluorescent and what's being blocked with the vessels. We have a superficial capillary plexus and a deep capillary plexus, and the choriocapillaries has a fenestrations which can leak fluorescent easily. So as has been covered by the Dr. Dinesh, the fluorescent is usually bound to proteins, but part of it is a free, and which can be leaked out of the choriocapillaries, not from the retinal endothelium. So general principles of the FAL, fluorescent is 85% bound to serum proteins, 50% unbound free fluorescent. We have two barriers, the inner blood retinal barriers, retinal capillaries, impermeable to fluorescent. Outer blood retinal barrier is a zonal occludens, impermeable to fluorescent again, and the choriocapillaries permeable to free fluorescent. There's a picture showing the fluorescent leak and the zonal occludens in the RPE leak if vascular permeability is compromised like in inflammation. Fundus angiography, general principles, excitation and emission, filters, photographic technique, phase of a normal angiogram, cause of dark appearance of fovea, cause of hypofluorescence. That's a basic thing which we need to know. So the excitation and barrier filter has been covered, and there's a excitation at 490 and a emission at 530. There is a over covering, which is going to give us a pseudo kind of fluorescence. And the causes of a dark appearance of the fovea is avascularity at that area where there's no vessels, blockage of the background choroidal fluorescence, increased density of the xanthophyll in the foveolar area, tall RP cells with more melanin. The common patterns, they are hyper, hypo, pseudo or autofluorescence, transmitted fluorescence. Autofluorescence, the autofluorescence occurs when a highly reflected structure such as optic nerve head, drusen, photographed prior to the injection of dye. Other examples, lipofuscin in retinal drusen and other abnormalities such as astrocytes, hematoma and angioid streak. Pseudofluorescence. Pseudofluorescence occurs as a result of a crossover in the spectral transmission curve of the exciter and the barrier filter, as we have just covered. If too much crossover is present, the reflectance from bright fundus structures will not be fully blocked by the barrier filters. Crossover can be the result of a mismatched or aging filters. Modern interference filters rarely exhibit a significant crossover unless they have deteriorated. Control photographs are routinely taken before injection of the fluorescence to detect the possible presence of a pseudofluorescence. Pseudofluorescence is the picture A, is a red-free photograph with a fluorescence filter without injecting dye, dark subretinal hemorrhage and a pale C-shaped lesion, dehemoglobinized blood, showing a hypofluorescence in the early and the late phase with the dehemoglobinized blood area where very faintly fluorescent. Causes of hyperfluorescence, the transmission, window defect, unmasking of the choroid, pooling in some space created there, leakage from vessels of choroid, retina, disc, staining, or any abnormal blood vessel. Causes of hypo, blocked fluorescence by pigment, blood, or exudate on the way, obstruction of circulation, loss of vascular tissue. These are the tabular form of the same causes of hyper and hyperfluorescence. And this is a picture showing the xanthophyll block and transmitted fluorescence through a RP defect. Causes of hyperfluorescence, vascular occlusions like capillary non-perfusion, venous occlusion, loss of a vascular tissue like in choroidemia or high myopia, pre-retinal hemorrhage causing hyperfluorescence, block of all retinal and choroidal fluorescence. A. Hemorrhage is located in the most of retinal layers from ILM to outer nuclear layer. B is a flame-shaped hemorrhage superior nasal to fovea due to branch vein occlusion. Angiogram shows irregular hypofluorescent block due to hemorrhage in front of it. This is a subretinal hemorrhage between photoreceptors and RP, scattered area of hemorrhage, blocked choroidal fluorescence, and visible retinal vessels behind, being deep in the location. This is the overlap. So the chirpy hypertrophic RPE, well demarcated hyperpigmented lesions, marked hyperfluorescence of a choroid due to blocked fluorescence in picture C. A is a choroidal nevus, B and C showing hyperfluorescence of corresponding to area of nevus. Optic pit with a cystic edema in the macula due to macular schisis detachment from optic pit. B shows early phase of AV phase showing hypofluorescence of a disc in the area of a pit due to absence of tissue and vessels. Late phase shows dark area of pit. Advanced choroideremia with the large choroidal vasculature can be seen as pale irregular lines. Early phase shows filling of a large choroidal vessels and retinal vessels but no choriocapillaries. Late phase again shows the large choroidal and retinal vessels and few choriocapillaries at the periphery. Central retinal artery occlusion with a known perfusion of the retinal vasculature, whole of it. And we have the causes of the hyperfluorescent RPE window defect, RPE atrophy, bullous eye maculopathy, pooling of the dye, under RP pigment epithelial detachment, under sensory retina CSR. Leakage of the dye into sensory retina assisted macular edema from new vessels, choroidal neovascularization, prolonged dye retention, staining associated with the drusils. A BR view with the hemorrhage, retinal whitening, and cotton wool spots, normal fluorescence of superior portion and subretinal hyperfluorescence of the inferior portion due to retinal capillary and non-perfusion. Very bright hyperfluorescence areas due to neovascularization. A and D, laser photocoagulation of subfoveal subretinal neovascularization. B, C, E, F shows early and a late phase of hyperfluorescence of macula, treated with a laser and some leakage of the retinal vessels in laser-treated area. Choroidal folds, hyperfluorescent lines corresponding to folds. Enlarged and fuzzy spots in late phase of due to accumulation of dye under sensory retina, showing leakage and the pooling. Pooling of the fluorescence in the late phase. Thank you.